So good morning. It's really a pleasure to be here today and kick off this great CME session. This session is supported by educational grant from Bayer Healthcare, Pharmaceuticals, Asahi, and Merck. And it really talks about the impacting the HCC outcomes using multimodal therapy and the importance of an interdisciplinary management team. It's a pleasure to be here moderating with Dr. Gandhi. We have three great speakers. These are our learning objectives. They're there in front of you to read, basically looking at challenges to optimal screening, diagnostic, and staging procedures, and how the team helps with that in the treatment of HCC, current guideline recommendations concerning resection, transplant, and use of local, regional, and systemic therapies in patients with HCC, pharmacological properties of novel and emerging systemic therapies for HCC, mechanisms of actions, efficacy, safety data, and indications, and then you apply the strategies for multidisciplinary care that incorporate a spectrum of treatment modalities for real-world treatment plans in patients with HCC. So with that, I'd like to welcome our first speaker, Ed Kim. Edward Dr. Kim is a good friend. He's a director of interventional oncology at Mount Sinai in New York, going to discuss HCC management. Welcome, Ed.
Thanks, Tino, and thank you for the invitation to come in and speak. Okay, I'll just get started on and speak a little bit. I've been asked to speak on HCC management. As we all know, the incidence of HCC is actually rising, despite all the antiretrovirals that have come out. If you look at the estimated new cases back in 2017, it's over 40,000, and the estimated deaths is close to 30,000. Historically, 20% of HCC is resectable, and contraindications that Gennaro will go over later on in terms of surgery include things such as significant portal hypertension, elevated total bilirubin, and low platelets. When we look at the primary risk factors for HCC, the ones that really stand out are Hep B and Hep C. Hep C has been under control with the antiretrovirals, and Hep B's incidence is decreasing with preemptive measures, mostly in, let's say, Middle East and Asia. But there is a rising incidence of NASH within the United States, and also alcoholic liver disease, as well as other causes. And these cause a chronic hepatitis, leading to cirrhosis and then development of HCC. When we try and understand survival outcomes, it's really understood within the framework of the BCLC. And I say it's, there are criticisms and people say that it's not perfect, but it is a common language between multiple disciplines to really discuss how to manage HCC and where relevant therapies go. And I think that's the key here, and that we'll learn throughout this symposia, is that a multidisciplinary approach to the treatment of HCC is really standard of care and mandatory. So going through this early stage, we have curative therapies, and these include transplantation, resection, as well as ablation. And with the intermediate stage, it's with a high level of evidence, chemoembolization has been firmly entrenched here. And in the last 2 years, in the advanced stage, there's been really an explosion of systemic therapies that have come out. For 10 years, it's really been Sorafenib, and Richard is really going to expound on that. And then there are just radioembolization that can be used throughout the BCLC stage, not as high level of evidence in terms of level 1 as the others, but certainly in practice, especially at Mount Sinai. So I talked about this multidisciplinary HCC team. You can see there are a lot of players here. We meet every Thursday morning with about 30 physicians in the room going over anywhere from 30 to 40 cases. And the players usually are, medical oncology, interventional radiology, surgery, hepatology, as well as the burgeoning field of SBRT in liver cancer management with radiation oncology. So the AASLD guidelines talk about a bunch of things, and it seems like things are changing on an annual basis, and it's quite confusing. And so that's where we really lean on our transplant team to help us guide us through all the guidelines that are really in a state of flux, along with UNOS's changing guidelines. Where we really come in for interventional radiology is really as a bridging therapy, waiting for transplantation, to really look at the tumor biology. That's what we're doing. We're trying to weed out all the aggressive tumors, and that's why there's a 6-month minimum mandatory wait list that was introduced back in 2015. There is evidence that ASLD supports in roles of downstaging. If we know the data on the Milan criteria, we know that those within Milan that Mazzaferro published in the New England Journal of Medicine show that those within Milan do extremely well. Just because you're outside of Milan, though, the argument can be made that it doesn't mean that you also do not do well. It's just a much lower percentage of patients that do well. So downstaging is supported and recommended. Locoregional therapy over no treatment is also recommended in T2 and T3 staging. And so this is for patients who are not candidates for resection or transplantation. However, the specific locoregional therapy is not expounded upon, but merely recommend that locoregional therapies be performed. And systemic therapy is endorsed for Child-Pugh A patients or Child-Pugh B with vascular invasion. In terms of UNOS point allocation, I alluded to the fact that in 2015, October specifically, there was a modified criteria that was established for those who are eligible for transplantation. And they have to meet T2 criteria or Milan, again, because of the article that was published by Mazzaferro's group showing that how well patients do who are within Milan criteria. However, there's a mandatory 6-month waiting period. And so during that 6 months, you're really observing the tumor biology. Is this going to become very aggressive where a transplantation would provide no benefit? Or is this something that will really provide benefit for the patient? And so most places will do some form of locoregional therapy in these patient populations with imaging assessment at every 3 months. And so every 3 months you gain MELD exception points with T2 priority patients starting at a higher MELD exception point with a cap of 34. So basically it's a point system where you jump the list. Those with the highest MELD points will get priority over others with lower MELD points. And then tumor patients kind of jump the line a little bit according to this criteria, but they get capped out at 34. So there was a modification again made in December of 2017, specifically regarding alpha-fetoprotein, which is a marker, tumor marker for HCC. And those above 1,000 are ineligible for transplantation because it's an indicator that you may have an aggressive tumor biology going on within the liver. However, if you can drop that AFP to less than 500 after an initial 1,000 with locoregional therapy, then you get standard exception points. Then a letter can be written on your behalf to say, this patient has now tumor that is relatively under control. We should give them a shot at transplant, which is a true cure. And then candidates over T2 who have been downstage are also eligible for standard exception points. So moving on in terms of specific staging, BCLC-A, these are patients that are really within Milan criteria for the most part, 3 nodules, each less than 3 centimeters, or a single tumor. That single tumor in the BCLC staging can be any size because surgical resection can be performed, which is a curative treatment. They have to have absence of macrovascular invasion or extrahepatic spread, and these are eligible by those curative therapies I discussed. Now, these are all the different regions for UNOS. Now, keep in mind, I know there are a lot of people from all over the country at this meeting, that a Region 9 is quite different from Region 3 in terms of transplant waiting list period. At Region 3, we were just discussing, most transplant individuals will really get transplanted probably around that minimum 6-month waiting period. And so maybe you do something like a TACE instead of a Y90 because potentially the shorter time to progression to bridge these patients. Whereas in Region 9, in New York, we wait usually about 2 years before patients can be transplanted, and that's the same with Region 5. And so you have different strategies and plans and different patient population depending on different regions. And that's not to even mention the fact that there were changes accounting for the regions with radiuses upon which organs would be drawn from, which is implemented and then has gone to court, and it was halted. So we're back to the 2017 recommendations. In terms of ablation, we know that from published literature, from Levrahi as well as Lee, that when you ablate lesions less than 2 centimeters in size, it's really equivalent to resection, and literature from multiple sources have shown that. We also know that there are thermal ablation pitfalls, either size, the larger it gets, heat sinks, and location against various critical structures such as the heart, the lung, as well as bowel, can lead to serious adverse events. And so not all patients are thermal ablation patients. And so they undergo what was described by Burrell et al. Out of the Barcelona group, and she described treatment migration, where you have a locoregional therapy that's really indicated for, let's say, the intermediate stage, such as chemoembolization in her paper, or radioembolization, and it migrates down to a earlier stage because a patient may be ineligible, for instance, with portal hypertension for resection. They are not a transplant candidate, and the location is unfavorable due to increased SAEs for ablation. And that's where we get this treatment migration, either with radiation segmentectomy or chemoembolization. Briefly discuss radiation segmentectomy because we perform a lot of it at Mount Sinai. We've published in peer-reviewed journals where you inject in a Cunode segment and then that infusion really simulates an anatomic resection. And Riaz and Vush really described this phenomenon first with a curative intent. And we published in JVIR that our results showed that radioembolization in terms compared to chemoembolization showed a time to what we could describe as secondary therapy when there's not a complete response on modified RECIST, and you have to retreat the patient, that radioembolization had a time to secondary therapy of 812 days as opposed to chemoembolization with 161 days. We also did a head-to-head that was published in Radiology that showed that there was no statistically significant difference in complete response rate, overall survival between ablation versus radioembolization in lesions 3 centimeters and less. And then Bob Lewandowski also published their experience at Northwestern showing an excellent response in lesions 5 cm and less. And this is just a quick case. The first case that we did radiation segmentectomy you see a 2 centimeter lesion next to the IVC. And he is now 8 years out with a complete response. I'm not going to go too much into this, but this is where the multidisciplinary aspect comes into play. When we talk about resection in cirrhotics, how much is enough residual liver volume? And so in general, you want to avoid resection in cirrhotics. So how can we increase the hepatic reserve? There has been described sequential chemoembolization plus PVE. Just PVE has really been shown to be only a benefit in metastatic disease and not really in cirrhotic patients with HCC because of the theoretical risk of hyperarterialization of flow to the tumor and progression. And so we use radioembolization in a lobar distribution called radiation lobectomy, and it's really threefold that we do that. It's as a neoadjuvant therapy for the tumor. It's to induce contralateral hypertrophy, and then there's a 3-month period that we wait, and we're really assessing the tumor biology at that time while treating the tumor and inducing contralateral lobe hypertrophy. When we go to the intermediate stage, we're really talking about multinodular patient, either unilobar or bifocal bilobar disease. Very good performance status, Child-Pugh A to B, and there's no extrahepatic spread or vascular invasion. In this patient population, chemoembolization really has been shown to provide a median overall survival benefit anywhere from 19 to 26 months with 40 to 50% at 3 years. And multiple studies have come out. Really, Low and Lovett back in 2002 showed that benefit versus best supportive care. Radioembolization, Riyad Salem challenges chemoembolization. He did a study looking at overall survival. And what he found was that the toxicity profile was significantly less in radioembolization versus chemoembolization, although he did not find that there was an overall survival benefit on one versus the other. There was also a provided longer time to progression benefit, radioembolization providing almost 5 months more than chemoembolization. And so that could be the impetus for Bob Lewandowski's study looking at radioembolization versus chemoembolization in downstaging T3 to T2 patients, which showed a statistically significant benefit in the size as well as the time to downstaging patients. Moving on to the advanced stage, we know that there has just been an explosion of systemic therapies, and I'm not going to steal Richard's thunder when he talks about all the therapies here, but this is just to put things into perspective in terms of how much has come out since Sorafenib. But when we look at a key demographic within the advanced stage, which is heterogeneous in its population, the specific population of patients who have macrovascular invasion have a more dismal prognosis, anywhere from 2.7 to 4 months. And a macroembolic such as chemoembolization is relatively contraindicated in this population because if you cut off the portal flow as well as the arterial flow, you're going to cause liver decompensation. So radioembolization, which is a minimally or less embolic therapy which relies on radiation, was published by Laura Kulik in a joint study with Northwestern and University of Pittsburgh. And they showed that approaching the 9-month mark, partial PVT as well as no PVT showed the exact same survival curve, at which point they diverged. This was also published around the same time by the group from Essen, Germany, that also showed a similar survival with a median time to progression of 10 months and an OS of 17 months in this patient population. And then multiple studies have come out by Guerin, Mazzaferro, as well as our group that showed a median OS that is similar across all the studies that have been published about 10 months, and that you get even higher survival rates when you increase the dose and target the PVT. Sarah and Sorafenib, studies that have come out, phase 3 studies, show that there was no overall survival benefit and progression-free survival between radioembolization versus Sorafenib. However, keep in mind that when you dissect the study, that 27 and 29% did not receive Y90, and about half the patients received chemoembolization beforehand, which limits the efficacy of radioembolization. Also, there was a heterogeneous patient population, including BCLC-A all the way through C, as well as main PVT. And absorbed dose, or how much dose the tumor received, was not reported on those studies. However, it did show that there was a significantly better quality of life compared to Sorafenib. So in conclusion, how do we navigate the BCLC? Well, a multidisciplinary approach is mandatory, with all the players really discussing the care of all these patients. Liver transplantation and resection remain the best curative treatment modalities. In the BCLC-A, thermal ablation is also firmly entrenched for a curative therapy, but those who are not and undergo a treatment migration can undergo chemoembolization or radioembolization. TACE plus PVE or radiation lobectomy are neoadjuvant therapies for resection in those with small future liver remnants, and locoregional therapy is recommended by the ASLD for bridging therapy for transplantation. In the BCLC-B patient population, we know that chemoembolization has been shown in level 1 evidence over best supportive care, but Riyad Salem challenges that with radioembolization in this patient population with a longer time to progression. And we can use locoregional therapies for downstaging therapy. In the advanced population, we know that there are multiple systemic agents that are out now, but take into consideration in a multidisciplinary approach that we use at Sinai as well, in that subselect vascular invasion patient, of combining potentially locoregional therapy with immuno-oncologic agents to potentially potentiate the effects of the two. And I think, in conclusion, that there are many studies right now that are trying to combine different modalities and across different subspecialties. For instance, neoadjuvant, potentially, let's say, a PD-1 or PD-L1 inhibitor prior to a resection, or using that in conjunction with locoregional therapy, whether it's in the intermediate or the advanced stage. So I think that is the future, and hopefully we can continue to collaborate in a multidisciplinary fashion. Thank you.
Thanks, Ed. That was a very nice review and overview of HCC. It's a pleasure to introduce my colleague in town, Dr. Gennaro Salvaggi, as head of liver transplantation at the Miami Transplant Institute. And he's going to be talking about the HCC guideline and adherence, as well as going through some of the transplantation criteria.
Thank you.
Good morning. Thank you, everybody. Thank you for inviting me. And I'll be talking a bit about the surgical approach, both in terms of resection and transplant. And I have no disclosures. Again, for early stages disease, as we just heard, the recommendations are for surgery. Sometimes locoregional therapy may be enough. And then the question whether to move towards surgery versus transplantation. In patients with child Pew A and B, if there's no more than 2-3 lesions, and again, platelet count less than 100,000, MEL below 12, some studies say MEL less than 9. One thing that's very important, the way I look at it, is the location of the tumor. You can have a 2-centimeter tumor peripheral, and you can have a 2-centimeter tumor schmeck in the middle of the liver that's going to require a large resection. That's a problem to decide whether to resect or not. And again, the amount of resection, the volume of healthy liver remnant. Portal vein embolization, as we heard, is a strategy, can be utilized. Absence of esophageal varices. One of the things we always ask in patients when we are uncertain is to do an EGD. If the scope shows big, thick esophageal varices, you know that the portal hypertension is advanced. Elderly population, very important. You have to have a favorable frailty index, which is becoming one of the hottest topics in both transplant and liver resection, and the absence of significant comorbidities. You can have an easy transplantable or an easy resectable patient. However, just the other day we had a person with an ejection fraction of 36%, 2 stents in the heart, in kidney failure on dialysis. Well, that guy is not going to get a resection, he's going to get locoregional therapy. Again, locoregional therapy is less invasive. You have a possibility of repeat or combined procedure, and it can be either a final destination therapy versus a bridge to surgical resection or transplant in our cases. Surgery versus transplantation. Where you see advantages in surgery is that it's kind of less invasive than the transplant. There is no need for immunosuppression. You can, in some instances, repeat resection more than once and does not exclude transplant at a later time. What are the disadvantages? There is a slightly higher rate of recurrence as compared to transplantation. It does not eliminate the cirrhosis, which means that new tumors can arise de novo in other parts of the damaged liver. And it can also lead to liver decompensation and urgent need for transplant or death if you take too much liver and the patient tips over, or even just an episode of infection or a leak after the resection can trigger the patient to go into liver failure. What are the advantages of transplant? There is the lowest rate of recurrence of all the modalities that we've talked about. Replaces the liver with a new working organ, so it improves all the symptomatology of the patient, makes all liver complications disappear, such as encephalopathy, ascites, and GI bleeding. The disadvantages, I should have put their cost, obviously. Second is the need for immunosuppression, at this moment lifelong. Second is a bigger surgery, bigger risks, and long-term complications such as renal failure, cancer risk, and so forth. For advanced stage disease, unfortunately, transplant does not become an option. Therefore, systemic therapy combined with some forms of locoregional therapy is more advisable. There is sometimes a small but possible window of opportunity for resection and transplant, and so some patients that have originally been discounted for transplant can be well treated with locoregional and systemic therapy and become a transplant candidate at a later time. These are small cases, but it's possible. If we look at the statistics, and this is from last year's OPTN report, this is kind of our Bible every year, of the 8,000 liver transplants that were done, 1,300 were done for malignant neoplasms, the majority of which, over 99%, were HCC. So about 16% of the cases we do every year. But if you notice the brown curve that dips down in the last few years, that's the curve of hepatitis C, because again, we have cured, so to speak, hepatitis C. And HCC has been slowly rising. That's the burgundy line that's been going up from less than 5% to about 16%. The survival of patients who receive a liver transplant, whether they have hepatocellular carcinoma or not, is virtually identical. So having tumor or waiting for a transplant with a tumor does not give you higher risk of death once you receive the transplant. The proposed criteria, the ones that we currently use, is still Milan criteria, which is 1 tumor between 3 and 5, or up to 3 tumors, each of them more than 1 and less than 3 centimeters. Multiple other criteria have been proposed, and there's vast literature to support their viewpoint. However, as it is currently, the Milan criteria are the only ones that are used by UNOS, which is the organism that runs transplant. Every other patient in the other categories needs to be adequately downstaged to Milan criteria in order to qualify for transplant. The exception policy, I'm talking here about adults, kids. First of all, there is not that many with HCC, but if they do, they go straight to status 1 to privilege them. The tumor has to be within Milan criteria. Of course, no CT scan of the chest could be positive, otherwise you have extrahepatic disease. Or if you see adrenal or bone metastasis, not a candidate for transplant. No vascular invasion. We're talking mostly portal vein and hepatic veins. Not a resection candidate, and there goes the decision, first of all, if you can resect or not. And the alpha-fetoprotein less than 1,000 and less than 500 if it was more than 1,000. We have to submit all this data every 3 months because we're observing the biological behavior of the tumor over time. So, what my colleague told you just changed in May. The letter up to 34 points does not exist anymore. The new exception score is called MMAT minus 3. I'll walk you through it. So first of all, the patient has to wait 6 months before he gets any extra points. Until then, remains with their biological MELD score. The MMAT is the median MELD at time of transplant in the past year in the radius, either the 250 nautical miles or the donor service area. We're still in the donor service area, but we're going to move to the 250 nautical miles. For us in Miami, it doesn't make a difference because the donor service area is the same as 250 miles because we're in the end of the peninsula of the United States. The score is updated every 180 days using the previous 365 days cohort. So as it stands right now in Florida, our MMAT is 28 points. Right. So the patient gets 28 minus 3 gets 25 points. For New York, I think it's 35, and the MMAT minus 3 is 32. So after the 6 months waiting time, the patient will get, wherever they are, those points. Now, the computer will automatically approve exception if you are within criteria, otherwise you have to write an appeal. And the bummer is that you do not get extra point every 3 months step. So in the case of Florida, for instance, once you get those 25 points, you cannot get 28 points 3 months later, 31 points 3 months later, and so forth. All you get is the change in the MMAT minus 3 every time the MMAT gets updated, so every 6 months. That is going to create, obviously, a bottleneck of a ton of patients with the same points. And I think you're observing that in New York as well, and we're seeing that here with a lot of patients with 25 points. So what are the effects of the new policy? There is a bottleneck. There is going to be more need for repeat locoregional therapy to bridge the patients for longer times. There is going to be a subselection of patients who actually may end up needing only locoregional therapy as destination therapy. Small single lesions, very stable cirrhosis. Tumor doesn't come back in 2 years. We might just say, just watch him. There's going to be a national realignment of all HCC patients towards similar staging at time of transplant. And of course, there's going to be very important for us on the transplant center to train the coordinators to do submissions. And every patient that does not qualify automatically, the case gets submitted with a narrative to the National Liver Review Board. Basically, there is surgeons and hepatologists all over the country. They get submitted cases for approval, and I'm in our region, I'm one of the reviewers. And the criteria have become very stiff. So just to give you an idea, there is 5 reviewers. If you need to get 4 out of 5 approvals in your narrative to be approved. If you get 2 no's, your case is denied, and you have to resubmit. So they've become really, really stringent on the criteria for approval for these extra points. So discussion points. The imaging studies, reading of region, and what we see a lot of patients that come from outside the transplant center. And we strongly advocate for the use of the LARET template, or at least to describe in the imaging studies those things that are important, that is enhancement, washout, and capsule. Why? Because when we list the patient and we try to get the appeal, there's checkboxes in each of the tumors for these things. If you don't check 2 boxes, which is either enhancement or washout or capsule, you don't get your case approved. If you get a CAT scan that does not, or an MRI that does not describe these things, it has to be reread by our local radiologist, and it spends time, and sometimes you cannot get repeat studies because the insurance doesn't approve new films and so forth. There are sometimes treated lesions where the original study does not match the above-mentioned data. Lesions less than 2 centimeters, it is my personal belief that unless biopsy proven, they should not be treated. You should wait until they become more than 2 centimeters because then you can qualify for future transplant. If you ablate a 1.8 centimeter lesion without biopsy, the patient will never be able to get those points. Imaging studies of Y90 treated lesions done too early. We see the patient that got radial embolization a month ago comes in with a beautiful MRI that looks like I have no idea what I'm reading. And most people, and you guys in the audience know, 3 months is the minimum, 6 months is the best result. When there is large tumor burden, portal vein or IVC invasion, alpha-fetoprotein about 1,000, there's room to work around the patient, likely not transplant, but we can always see the patient and decide together. And again, sometimes patients are sent to us after failure of multiple treatment. We have private hospitals in the community, not Baptist, where a patient is treated by, laparoscopic radiofrequency ablation of a 12-centimeter tumor. And then TACE of the same tumor. And then when the tumor recurs peripherally at the 2 lesions, now it's time to send the patient for transplant. Oops, a little too late. Adherence to guidelines. Again, surveillance studies. Yes, the papers say ultrasound. If anybody comes to me with an ultrasound, I'm going to ask for a CT or an MRI, because to me, with a ultrasound, unless you're in Japan where you have contrast-based ultrasound in patients that are all 50 pounds and not 350 pounds like the guy did the other day, you cannot see anything with an ultrasound. Frequency of imaging studies. Guidelines say every 6 months if you're cirrhotic, 3 months if there's positive studies, and 1 month post-procedures. Imaging guidelines, again, we recommend the use of LIRAD. Management guidelines, the BCLC criteria are the most commonly used, but truly there are no really established worldwide accepted guidelines for decisions on resection versus locoregional therapy. Multidisciplinary approach is the most important. Again, it's the standard of care in large centers and academic practice, not so much in local community hospitals. Dedicated tumor board with all the people there that we were just discussing. And the benefits: faster referral, seamless horizontal movement through different disciplines, unified medical records and imaging repository, data collection, abstraction, statistics, and also for publication, and intervention radiology, oncology, combined clinics. In conclusion, the multidisciplinary approach with fast referral to tumor board is best practice. Avoid late referral to transplant, especially in patients who already have a lot of portal hypertension. Know that the biology of tumor can vary significantly among patients within each patient over time, and be ready to modify the plan of action. And last and not least, communication, communication, communication. And I'm going to hand it over to Richard.
Thank you, Gennaro. The last talk here is going to be given by Dr. Richard Kim. He's a medical oncologist at Moffitt Cancer Center. He's going to be talking on the update of systemic treatment options for advanced HCC. I think most of the advancements that we've seen over the last couple of years has really been in systemic therapy, so this is really an opportune talk.
Thank you very much for the organization for inviting me to give this talk. So I'm a medical oncologist currently at the Moffitt Cancer Center, Tampa, Florida, not too far away from here. And I was given a task of sort of updating you guys on the systemic treatment options for advanced hepatocellular carcinoma. And as you mentioned, we've come a very long way in terms of the management of this kind of patients. Here are my disclosures. So in the treatment of advanced hepatocellular carcinoma, as you guys know, Sorafenib was approved back in 2007 when I was actually a fellow at that time. Then, since then, there has been many attempts to beat Sorafenib in terms of phase 3 studies. And unfortunately, most were all negative until recently when the positive data started to come out since 2017. So let's start with the first-line treatment. As you know, the SHARP study has been the standard of care for many, many years. And I must say, because of some of the toxicity profile, not everybody was very enthusiastic about giving this drug. However, having said that, this was the first study that was positive in a phase 3 setting, beating in a patient with advanced hepatocellular carcinoma. There was improvement over survival compared to placebo. And based on that, this drug was approved back in November 2007 in the treatment of advanced unresectable hepatocellular carcinoma. Since then, as I mentioned, most of the trials were negative until recently. There's a reflex study that was presented a couple of years ago where this was actually a non-inferiority study, okay, in patients with advanced hepatocellular carcinoma who basically, if you look at the inclusion criteria, there's subtle differences between a SHARP study. The one was that the patients with 50% liver occupation, so patient with a high burden of disease or clear bile duct invasion or portal vein invasion at the main portal vein were excluded. So they excluded patient with a bad actor. Okay, so this is something that you have to distinguish between the SHARP study. And the study was basically randomized between a lenvatinib based on the dose, based on the weight, the dose was different, versus sorafenib. And the primary endpoint is overall survival, and the secondary endpoint, as you look at here, is PFS, time to progression, response rate, and quality of life. And the trial was positive. The endpoint of non-inferior was met. If you look at the overall survival, the lenvatinib had an OS of 13.6 months, sorafenib had 12.3 months. If you look at the Kaplan-Meier curve, it's very similar. However, the secondary endpoint was superior arm with lenvatinib. There was a longer PFS, longer time to progression, and the response rate was much higher. Actually, if you go and look at the modified RECIST criteria of response rate, lenvatinib had a close to 40% response rate. So despite having a median overall survival very similar and the primary endpoint was met, the secondary endpoint was much superior in favoring the arm of lenvatinib. So as a clinician, when we see a patient that gets referred to us by surgeons or IR folks with an advanced hepatocellular carcinoma, mostly BCLC stage C, how do you decide what to do? And as I mentioned to you, in terms of the OS data, it was very similar. But there are set of differences that we look at. Number one, as I mentioned to you, is in terms of the inclusion criteria, in the arm of the reflex study, they excluded patients with the high burden of disease and the main portal vein invasion. In terms of the efficacy-wise, it's similar in OS, but there is higher response rate. So if you have a patient with high tumor burden or symptomatic from disease, maybe the lenvatinib is your choice. There are subtle differences between hand-foot skin in terms of the toxicity profile, which I didn't have time to go over in detail. But if you look at the arm of sorafenib, there was increased hand-foot skin reaction compared to lenvatinib, where there's more increased hypertension, proteinuria, and anorexia. Okay, and how the drug is given is a little bit different. The data with sorafenib is that it's given twice daily, it's BID dosing, versus lenvatinib, which is a once-a-day dosing. I think other important thing is that because the sorafenib has been around since 2007, there's a lot more data of safety data using sorafenib in Child-Pugh B patients. One of the things that we see as medical oncologists is that the patients we see in our clinic are not Child-Pugh A, 5, or 6. They have 7, Child-Pugh 7, B, 7 or 8 kind of scoring system. But sorafenib, there's a lot of retrospective and some prospective data that it is probably safe to give sorafenib at a lower dose. On the other hand, lenvatinib, there's some data from a group from Japan, but otherwise there's not much data using this drug in Child-Pugh B patients. So that's something to think about. Moving on to second-line randomized study. If this was a patient that I saw maybe 2 years ago or maybe in a year and a half ago, there was no standard second-line therapy. But now we have a couple of drugs that's available in second line. So one of the drug that was approved in second line is a drug called regorafenib, which a lot of medical oncologists have experience using in colorectal cancer. But the resource study was a patient who, in a second-line setting, a patient who progressed on the first-line treatment with sorafenib. And they were randomized basically 2-to-1 to regorafenib versus placebo. And the primary endpoint of the study was overall survival, and secondary endpoints PFS, time to progression, and response rate. Of note, for the inclusion criteria for this study, the patient must have tolerated sorafenib at least 400 milligrams once a day. Okay, so if they did not tolerate sorafenib, those patients were not included in the study. And the trial was positive. In second-line setting against placebo, by giving patient regorafenib, there was an improvement in survival close to about 3 months. It went from 7.8 to 10.6 months. And if you look at the Kaplan-Meier curve, it clearly separates, okay, so showing the advantage of regorafenib in this setting. Then there's another TKI called cabozantinib. Cabozantinib is a dirty TKI as well, but it blocks a little bit different pathways. It blocks VEGF, but also blocks the MET pathway, AXL pathway, so a little bit the different kind of TKI. This drug was also studied in second-line setting in patients who failed sorafenib. Of note, that once again, the eligibility criteria was a little bit different. In this study, they allowed up to 2 lines of therapy. Okay, and here they also allowed patients who were intolerant to sorafenib. Okay, and the trial was randomized similar to the resource study, 2-to-1 to cabozantinib versus placebo, and the primary endpoint was similar on overall survival, and the secondary endpoint was PFS and response rate. And in this study, once again, to point out, though, about 30% had received at least 2 previous systemic therapy. This is more like a third-line therapy in those patients. And the trial was also positive. It was very similar. If you look at the Kaplan-Meier curve, it's very similar to the resource study. There was improvement of survival about 2 months, favoring the arm of cabozantinib. placebo is 8 months versus 10.2 months in the arm of cabozantinib. And based on this study, this drug was approved in the treatment of advanced hepatocellular carcinoma in patients who were previously treated with sorafenib. Once again, if you do a post-hoc analysis, just looking at patients who failed one-line therapy, the magnitude of benefit of overall survival is greater. That's as expected. But overall, in all patients, there was about 2 months improvement over survival, and this is how the drug got approved. Now, it's also available for use in our patient as well. Third drug that got approved is a drug called ramucirumab. If the med-oncs we know this drug very well because it's been used in gastric cancer and colon cancer. But this is it's not a TKI, it's a monoclonal antibody that blocks the VEGF-R2, so the VEGF receptor 2. So it's not a TKI, okay? And this drug was studied in a similar setting in second-line setting, in patients who failed first-line therapy with sorafenib. The key difference here is that they only allowed patients with AFP greater than 400. And there were patients who were randomized 1-to-1 to ramucirumab every 2 weeks versus placebo. And they obviously, the primary endpoints, similar to other studies, were overall survival. So this was a REACH2 study. So if there was a REACH2 study, there was probably REACH1 study. And the REACH1 study is the one that allowed all comers. And that trial was actually negative. There was no difference in overall survival when you compare to placebo. But when they went back and did a post-hoc analysis, they found out that patients with AFP greater than 400 actually benefited from ramucirumab. Okay, and that's why they did a REACH2 study, and they would only allow patients with AFP of greater than 400. And by doing that study, there was an improvement in overall survival. It was the placebo arm was 6.6 months, as you could see, and the ramucirumab was close to 8 months. So the p-value is very significant, and now this is based on that. This drug was approved in second-line setting in patients who have AFP greater than 400, which is one of the biomarkers that obviously we check every couple months. So when you have a patient that comes in for second-line therapy, now how do you consider what drugs to use? Luckily for the patients, we have a lot more options than we did a couple of years ago. So there are 3 drugs currently approved: regorafenib, cabozantinib, and ramucirumab. Once again, there are subtle differences. They all showed overall survival data based on a large randomized phase 3 study. So these are all level 1 evidence. However, as I mentioned to you, there are subtle differences. Number one, with the regorafenib is that you only allowed patients who were able to tolerate sorafenib. So if you have patients who are intolerant to sorafenib, regorafenib is not the choice. Cabozantinib, on the other hand, it allowed patients who were intolerant to sorafenib. But technically, you could use this as a third line because about a quarter of the patients in the study got more than 2 lines of therapy. Ramucirumab is only restricted to patients with AFP greater than 400, right? Because that's the only subset that showed positive overall survival. Okay, so there are some other differences that. Other thing that we look at is the toxicity profile. The regorafenib and cabozantinib are TKIs. Those are what we call dirty TKIs, meaning they block many pathways. That's why they have many side effects, obviously. The ramucirumab, on the other hand, is a pure VEGF-R2 blocker. So only side effect you have is basically anti-angiogenic side effects. Okay? So generally speaking, as a single agent, it's very well tolerated with low rates of reduction and discontinuation, even though there's a little bit high risk of bleeding and ascites. Okay? So something to think about. Other thing in terms of logistic-wise, that regorafenib, cabozantinib is a pill, is oral. On the other hand, ramucirumab is IV infusion, which is given every 2 weeks. So subtle differences. But obviously, we have a lot of choices, at least for the patients. And depending on each patient's scenario, we would make one versus the other choice. Immunotherapy. I think I have a couple minutes left. But obviously, immunotherapy has got a lot of attention. And we thought this was the next best thing that's coming up. So I just put a question mark there. And reason for that is I will tell you some of the reasons why now it's sort of becoming a question mark. One of those data that was presented by Anthony about many years ago in 2015 or I think 14 in ASCO was a Checkmate 040 study. As you know, there were many arms in this study. But one of the first arms that was presented was the nivolumab single agent. Okay, that was a phase 2 study, single agent study that was first presented. And there were other arms in that study, for example, randomization of nivolumab with sorafenib first-line study, nivolumab in child PUB patients, and the nivo plus ipi combination. All the data has been so far been presented to some point at our congresses. For this meeting, I don't have time to go through every one of them, but I'll go over some of the main ones at least. So the main one is the single arm study that got the nivolumab approval by the FDA. And this was based on a pretty large study, single arm. At the beginning, there was a little bit concern about liver toxicity. Okay, so they started very slowly. They had a separate cohort for Hep B, Hep C, non-infected cohort. The bottom line is there was a response rate of about 15 to 18%. And the important thing is that these response rates were very, very durable. Okay, based on that, FDA took a look at it and gave it approval. Once again, but this is based on a single-arm phase 2 study. This drug is not approved anywhere else but the U.S., okay? But once again, very positive results, very durable response, and this is how the drug got approved. Same thing happened with pembrolizumab. Keynote 224 study is a single-arm study, phase 2 study, okay, in patients with advanced hepatocellular carcinoma who failed basically one line of therapy. And similar to nivolumab, the response rate is hovering around 15 to 20%. And similar to the CheckMate study, these are all very durable. Okay, so these are something that we have not seen in the past when we treat patients with HCC. However, the enthusiasm from this sort of dampened when all of the negative study came out when they started randomizing study. This is the key point is that's why, we look at a lot of retrospective stuff, post-hoc analysis, but I think that's why you need to do a randomized study to really show if it shows benefit or not. So this was a Keynote 240 study that Rich Finn presented at ASCO a couple of months ago in Chicago. This was a sort of a phase 3 study, randomizing now in second-line setting in pembrolizumab versus placebo. Okay, because at that time there was no standard of care. Right now, these kind of studies will be tough to do. But after 13 months of follow-up, okay, even though there was a trend, the response was very similar at 15%. Okay, and there was a slight maybe improvement in PFS. However, these differences did not meet the significance per the statistical plan. So trial was actually negative, even though, once again, there's a trend towards improvement in PFS and maybe trends towards overall survival. So unfortunately, this was a negative study. The CheckMate 459 study was just presented at ESMO a week ago. This was a first-line study that randomized nivolumab versus sorafenib. When this trial was going on, everybody thought that nivolumab would win. Right? There's no doubt, okay, because it's an IO, it's tolerated very well, and we have a very durable response, okay? And this trial had a dual endpoint as a time to progression and overall survival. And as you know, there was a press release like 2 months ago saying that it did not achieve statistical significance for its primary endpoint of overall survival. And this was the slide from the ESMO. I did not attend ESMO, but these are the numbers. Okay, once you can see, there's a slight maybe trend towards improvement over survival from 14 to 16 months. But if you look at the PFS, was similar. Response rate, just like the other studies, about 15%. And in this study, they did also look at the sort of the PD-L1 expression as a potentially biomarker. And there's maybe a trend towards a higher response rate in patients with PD-L1 positivity. But once again, even the patients who are PD-L1 negative will also show response rate as well. Just one key point about this study is that the arm of sorafenib had a median overall survival of 15 months. Remember the SHARP study that I presented to you that was 10 years ago? In that study, it was about 10 months. So we've made some progress, even despite this trial being negative. So I think I'm over my time. So where do we go from here? Okay, so IOs, unfortunately, phase 2 study, single arm, shows positivity, duration, but all the phase 3s were negative. So I think now sort of the areas of research that we're going on is trying to, how do we expand on that? We know certain patients do benefit from immunotherapy. There's no doubt. I have patients who's an IO for 2-3 years, which we did not see with TKIs. Okay, but it's not the majority. It's about 15% maybe. Okay, so how to expand that? And I think these are a couple of ideas that's being thrown out there that's preclinically and clinically being done. One is to possibly enhance tumor-associated antigen exposure by giving radiation, SBRT, local therapy. The second thing is that trying to enhance the intrinsic activity, combining the IOs, CTLA-4, OX40, LAG-3. So those are trials ongoing right now. Another thing is that trying to change the microenvironment. And that's a hot area right now. And how do you change the microenvironment? By adding anti-VEGF, bevacizumab, for example, or adding a TKI, okay, that can change the microenvironment of the tumor so that it could be more responsive to immunotherapy. So one example of this is that the phase 1 trial of lenvatinib. I mentioned to you the reflex study, okay, of lenvatinib. They did a study with lenvatinib and pembrolizumab, and the rationale behind is that the lenvatinib or other TKIs, that actually it changes the microenvironment to be more responsive to pembrolizumab or immunotherapy. And in this small study, once again, 26 patients, the response rate here was about 40%. Okay, so much higher than a single agent pembrolizumab, much higher than single agent of lenvatinib. Okay, so this example here, and based on that right now, there is a LEAP study going on right now, which is a phase 3 study going against lenvatinib plus pembrolizumab versus lenvatinib alone. And even at Moffitt Cancer Center, we have a trial going out with regorafenib plus nivolumab. So same concept, okay, we combine the different TKIs and IOs. So once again, this is just a quick example here. Now, there are many, many studies that are going on right now combining local therapy with immuno-based therapy, okay, whether it's combining with TACE, doxorubicin-loaded TACE or Y90. So there are many, many studies that are going on right now trying to, once again, to get a synergy of combining local and immune-based therapy. So conclusion, I think over time here is that I think the first-line treatment, I think sorafenib or lenvatinib are reasonable options. There are subtle differences, as I mentioned to you. In second-line therapy, there are many drugs out there, regorafenib, cabozantinib, ramucirumab. These are all level 1 evidence, okay, which is very important. You know, once again, immunotherapy, there's no level 1 evidence because of the negative phase 3 study. However, having said that, once again, there are no doubt about subset of patients do benefit from it. Right now, we don't have a biomarker to tell us what it is. I think the future is a combination. I clearly believe is whether it's TKI or IO plus IO or local therapy plus IO. Some of those combinations will be the way to go in the future. And I think the last but not least, we need better biomarker development to enhance the patient selection and to minimize unnecessary exposure. Thank you very much.
Thank you, Dr. Kim. I think we have maybe time for 1 or 2 questions from the audience before we go to the polling questions.
Any questions? I'll have a question. Dr. Kim, so you talked about sorafenib and then lenvatinib. How do you make that decision? A patient comes to see you, and you're going to start one or the other. Can you go back and talk a little bit? Because I thought on your slide you really talked a little bit about your decision maybe based on.
Yeah, so I think, obviously there's no right or wrong answer. We have a lot of experience using sorafenib, so we are used to using it. In patients with a child PUB patient who don't have pure child PUA, I tend to go with sorafenib because that's a drug that we've had a lot of experience using. On the other hand, as I mentioned to you, lenvatinib does have a higher response rate, so you do see a biochemical response in those patients as well. So I think in a patient with high burden of disease who are symptomatic, I tend to go with lenvatinib as well. So I think they're both good drugs, but I think in terms of response rate, definitely clinically, I do see more with lenvatinib for sure.
Any other questions? I have a question for the other Dr. Kim. So how many times you see a patient that you evaluate in your conference? You talked about how you have a multidisciplinary conference, and you may see that the patient doesn't qualify, and you send them to get systemic therapy. How many times do you see that patient come back, and how important is it to continue to follow that patient and communicate with your medical oncologist in terms of possibly coming back and then going into transplant?
Yeah, that's actually an excellent question, Tino. So there are cases where we feel that local regional therapy would provide no benefit for the patient. We've had a patient, for instance, that's actually on the Sinai website as a testimony, not under our service, but he had macrovascular invasion invading into the IVC, the portal vein, and everyone said he's going to have less than 3 months to live. He actually went on Lenva and Pembro on study and had actually a complete response. We did some reconstructions for the IVC and portal vein to reestablish flow, and we've been following him in conjunction with our medical oncologist. And he's now almost 3 years out, but had a recurrence, even though he's still on treatment, let's say for a segment 8 2-centimeter lesion. That was definitively HCC. So we treated that lesion with local regional therapy, had an excellent response, and now he's a year out from that. And so I think we're in an area that is very exciting. I think that we need to combine the therapies. Now, Richard presented the data as is, and so the objective response rate in certain studies, they were non-inferiority studies, and also we're talking about 20%. And so I think obviously there's room to improve, and I think where we do that is really in a multidisciplinary fashion and combining systemic therapies and their benefits, but patients are going to progress. This is not a true cure. And so we need close surveillance and follow-up and supplement with either systemic or vice versa with locoregional therapy. Or maybe a patient even gets eligible for resection or transplantation. Who knows? We're in a very new area.
Well, I want to thank everybody for attending. I want to thank the excellent speakers that we had this morning. Thank you very much for attending.